Thank you, Professor Chung, for your introduction, and welcome everyone from across the world to join this webinar from the Hong Kong Polytechnic University School of Nursing. So today, our topic is about how to bridge the compassion and algorithms and what kinds of nursing capabilities for an AI-driven future. This conversation is so important right now, given that we have a huge nursing workforce shortage all around the world. And then we also have an unprecedented AI adoption in healthcare. AI tools has been started to use from the clinical to community and also in education period. So the bridging route is how we can bridge our compassion and AI together to ensure that they can deliver person-centered care. So our goal is to define the capabilities our nurses need to lead AI transformation in healthcare. So central tension right now, what we are talking about is, do those AI machine care? And are we as nurses can lead this care in the AI environments and how? So from our understanding, usually compassion is quite contextual, embodied, and quite culturally saturated how we develop compassion care with our patient in human touch. However, algorithms is more pattern-based, right? They are scalable, they can predict numbers very well, they can be bounded by the training data. And it makes that how we can translate our nursing irreplaceable roles or contextualize our human touch within the algorithm is the main problem to choose whether we can deliver compassion care through the algorithms or how we can bridge these two much closer. So the agenda for today, we have 4 sections. The first is the overall landscape about healthcare in nursing with AI. Part 2, we talk about some nursing capabilities. What were the traditional competency and what are the hybrid or the emerging competency we need to learn as a future nurses? And the third part will lead to some digital and analytics skill sets under the current wave of the AI and LLM. The part 4 is how we can actually integrate compassion and algorithms as a nurse. So part 1, talking about the overall landscape in AI, healthcare, and nursing. So the overall broad term about AI is an umbrella term, cover all kinds of tasks that they are training a system to learn a human think or a human ed. And there are 2 subfields very significantly talked about over the past decade, including machine learning and deep learning. So you can see from the right-hand side showing the machine learning technique is actually, they can learn from the training data set. Usually they learn from the data you provide to the computer. And then deep learning is actually the subset from the machine learning, which is actually to learn about how the brain function, the neural network works between items to items or document to documents. So you can see from the item 2 here, subfields means machine learning, deep learning, natural language processing, and computer vision. So natural language processing here means they are analyzing the text instead of the numbers. They're trying to make the computer to understand the text and then try to transcribe these texts into numbers. So at the back end, they are still numbers, but at the front end, they try to translate this to the numbers to analyze what are you talking about, why you're talking about. So that's why they generate some human-like text based on the natural language processing. And computer vision most likely talking about the images. So for example, you can train a lot of radiology films with computer vision because they learn the patterns of the image and try to annotate different part of the images to make the computer understand which part have tumor, which part don't have tumor. Another term very important by AI is the predictive analytics. So you can see a lot of AI models, especially with the machine learning and deep learning, they train with the predictive analytics. They try to interpret what would be the risk or what would be the deterioration alerts, how would be the readmission prediction based on the previous training data set. And the final part is actually the most important part right now, given the trend of large language models. So generative AI, this term emerged in 2024, right after the OpenAI launched ChatGPT, and it is also under AI firm. However, it's a subset also from machine learning and deep learning. So they can actually produce text or summaries in a human-like text. So across the care continuum, you can see AI has been applied in prevention, diagnosis to triage, or care delivery, how to do some smart infusion pumps using in their robotic assistants, how to coordinate with the care coordination in discharge planning tools, providing some referral guidelines or care pathway recommendations. And finally, also it's very commonly used in education and simulation. One of the example here is we use the development of machine learning to predict the inpatient acute kidney injury prediction model. So the data source they use here is the electronic health record from observational retrospective data from adult hospitalized inpatients. And then they try to develop the machine learning model using longitudinal inpatient data. The objective is to predict whether they have any acute kidney injury prior to any changes in the serum creatinine. So they use the matrix, say AUROC, or like the sensitivity or specificity. These terms is very similar to exactly like our pre-core, like the past the false positive or false negative. They just change these terms in a more engineering ways. So don't be scared by the matrix. Looks very different from our nursing usual evaluation matrix. So this paper also demonstrates how this could support closer surveillance and also earlier escalation in the hospital, and we can prioritize some high-risk patients much earlier. The second one is to use zero-shot learning to extract some assessment criteria and medical services from the preventive healthcare guidelines using LLM. So they use zero-shot means they provide nothing for the AI. They didn't provide any examples. They just use the LLM to pre-train the model to extract the guideline from the written text. Okay, so they also use their precision recall and F1 score to evaluate the performance. And then they want to translate to convert this unconstructive narrative recommendation into a more structured assessment, which means they are trying to make your text quantifiable. Okay, and then they can quantify the text from a written text and trying to reduce the manual review, because usually we require the nurses to manually check over these texts and then quantify this kind of data to predict the assessment criteria. But this time you can make it very easy and accessible with computable care guidance. Another example here is they use the electronic health records for patients with possible GI bleeding. And they also use LLM to explore or detect the GI bleeding from unstructured documentation. Usually those could be from the clinician's documentation. So this could also identify earlier signs for people who might have GI bleeding and to support the surveillance from the routine clinical documentation. So this means that if your country has been applied a digital documentation, that would be very easy to deploy. However, if your country is still using handwritten documentation by the clinicians, that might make their system very difficult to understand, because those handwritten texts might be difficult to be interpreted by the computer. And the LLM could make mistake based on these handwritten texts. So that's something we have to aware with. Another real-world example is a study from our team. We developed a neurobot to support patients with neurosurgery. We collaborated with the QEH Hospital in Hong Kong and gathered the validated assessment and the feedback from the neurosurgeons and their advanced practice nurses in the hospital to validate this neurobot. So what this neurobot we're doing is we actually employed the nursing guidelines and also the nursing care plan with neurosurgery embedded to this chatbot. And then the patients, before and after the surgery, they could actually check with the chatbot about what kinds of side effects or what kind of preoperative strategies they need to prepare before they get into the operation room. So I really found that their expert rated very well with accuracy. relevance, and the completeness, which also the qualitative insight can highlight that the neural board have potential to reduce the staff workload because these patients might not ask their nurses anymore about the side effects because those are very factual and easily to be retrieved by the LLM or the chatbot. And this could also enhance the patient education and deliver evidence-based responses because all these responses have a directional behind. And we can also embed with a link for the patient to read those preoperative guidelines or post-operative side effects management. Another example in nursing education is actually when we have to deal with a lot of questions by the students because in nursing we have more than 400 students per year. So before they came to the teachers for asking for feedback, I personally trained a LLM model for grading their homework. One of their homework is they have to pitch an idea for the managers or investors or patients. So the target audience could make your pitching script much different, right? So I trained it with my previous grading assessments, and then I fit it into this pitching script analysis model, which could allow the students could receive my personal feedback 24/7. So now they don't need to come to see me every time after they have to submit their homework before. Usually they would have to arrange consultations, but now they can use the system right now here first to get my personal feedback on their system before they fine-tune their homework for their submissions. And from these results, we can also see that they reported quite positive with a prompt and personalized feedback. And we also evaluated this with the control group that actually the intervention group achieved better in their pitching scores after using it for 3 times. Okay, so after talking about some examples in clinical science and also from the education, this one is more about some data we might not be able to capture from the electronic health records. So usually in the electronic health records, those data were written by the clinicians, right? Nurses, doctors, OTs, PTs, radiographers. However, we did not capture their responses or their feelings or the experience from their patients. So that's why this study, we utilized the online health communities, including the Reddit, online health support groups, or like threads, or some cancer-specific support groups. We use large language models to collect their data. So this one, we selected patients with cancer, and we want to look at what kinds of narratives they have been expressed in the online health community. So we conducted the topic GPT model, actually a new model to encode what kinds of topic these people has been expressed in online space. And we also conducted a social network analysis to see how they connect each other with different types of topics. So here we got about 11,000 posts were collected from 4 online health communities. And of these, we have about 3,000 posts were retained for topic modeling and networking analysis. So you find that there are some high topics diversity across languages, including fear of cancer recurrence, psychological distress, and also, we find strong connections among these topics like sexual health concerns, reproductive concerns. And this topic were actually rarely reported from our electronic health records from the cancer patients in EHL. So we find it very important to merge the gap from this topic modeling in the online space into the understanding the cancer pathway. So we can see the potential benefits of nursing, including reduce the burden, having faster access for some factual information, and we could also enhance safety with a stronger surveillance and safety net for deterioration. The fourth one is to improve education and advance the stimulation in different ways. However, they are not perfect. All the AI have some issues and limitations, and some of the common issues including automation bias. Because when we're too over-reliant on the algorithm recommendations, there might be some weakening the student's ability or the nurse's ability to think independently. And the second one is also very important, is about algorithmic bias. These bias including whether the training set has been included some race, people who were well captured in the training set. For example, some ethnic minority groups in Hong Kong might not be captured in the electronic health records properly, or it couldn't represent some disability groups. So we have to be aware of this bias. And of course, privacy issues, erosion of our patient and clinician communications or relationships. And the fifth one will be all very applicable to the areas in low resource countries about digital divide. Even though Hong Kong is a very well-developed country, the digital divide also could have some impact in their digital literacy. So people have different AI literacy could also receive different types of consequences of bias. And the last one is the useness tools. Some tools might just use it for like metric reporting, but might not actually improving our nursing workflow or improving any patient outcomes. So now we move to part 2 about what kinds of nursing capabilities we have to evolve or we have to change from our traditional mindset to a more hybrid and emerging competencies. So some traditional nursing competency, including clinical assessment, bedside judgment, how to develop our therapeutic communication and empathy with our patients, right? However, given the growth of the AI and the new analytic tools, it becomes more important to understand how AI developed the training sets and how, as a nurse, could help with this training to improve their outcomes. So here are some emerging digital competency, including how we can interpret the AI insights, how we understand what the AI has been trained, and also what were the uncertainty we are actually posing to the patients. What kinds of digital workflow navigation we can modify or apply some informatics analytic skills in our text or the digital data from the EHR. And the last one is also mentioning about how we can verify the AI recommendation when it is conflict with the clinical reality. I'm not sure anyone has been read some papers or some commercial products about the AI's accuracy. Usually they report quite high, right? Like 99%, 98% of accuracy. However, there's always a gap when we apply to the clinical side. The accuracy drop a lot. And that's the problem why we have to gear up our capabilities among the nurses to identify these gaps and to improve their outcomes. So here are some of my insights about what kinds of critical nursing capabilities we need to train the nurses. The first one, definitely critical judgment and critical thinking with AI. The second is about advanced communication and empathy, which becomes much more important under the current wave of AI. The third one is, do you have enough analytic skill set to understand prompt engineering or some AI agents? How does they work? How nurses could employ these kinds of agents into your nursing workflow ethically? The fourth one is about systems thinking, how we interpret the data and inform the dashboard development during the collaboration with the engineers. That's why we lead to number 5 and 6, how we can, as a nurse, to ethically advocate the nurse's role and collaborate with an AI-enabled teams. So regarding the first one about critical judgment and critical thinking, have you heard about the slang about garbage in and garbage out? If you do, that's what actually we used to teach people and also the nurses. When we evaluate the AI output, the first question you should ask, what kinds of input has been provided? How did you train the input? So you need to understand the input, the output, the process between them, and the limitation of the AI tools. So these process require some basic understanding of AI. The second one is you need to understand some uncertainty. At what case this system will be out of distribution, or at what case this system might not work as perfect as they do. So you have to know the boundaries of the AI system based on your clinical knowledge and experience. The third one is to document some AI influence decisions transparently in the health record and know what to override, what to escalate, and participate in some usability feedback or co-design of AI integrated workflows. So I think empathy, I don't need to explain too much here because the trust is therapeutic. AI could actually use some languages to mimic they have empathy, but still the patients will feel it with our human touch and also the presence or the genuine connection. So that's why the algorithm might know the pattern well, but actually the nurse knows the person better than the AI. And there are some empathetic design in AI integrated tools, such as we could employ the technology how to free the nurses from repetitive administrative tasks. And also we can design some kind of real patient and staff experience, considering some fear or pain in the care settings and how to ensure these AI tools are intuitive. Also protecting dignity, include nurses in co-design, and also the equity inclusive measures. So part 3 related to some digital and analytic skill sets. So these are the GenAI tools from Turing.com, which is also very commonly used and reputable right now. And it's starting from 2003. I just captured the second screen here. You can see the model right now changed to more reasoning models compared to the models published 2 years ago. And why prompt engineering matters to nurses is because if you didn't know how to ask a right question with your clinical experience, the output from the prompt engineering or the output of the AI could affect your decision. So make sure in your prompt engineering methods could align with all the important criteria. So here are some anatomy to see how we develop the clinical prompts, which include the role, the context, what kinds of tasks you want them to output for you, formatting, and the guardrails is the most important part. Remember to guide the AI, what are your clinical judgment? Do not disclose something or do not diagnose thing like a nurse with some limitations. So we also try to use different types of prompt engineering skills, including some closed-ended or open-ended prompts. So you can strongly to see some examples about what kinds of prompts you could use. The last one for the role play is usually used for the nurses who want to develop communication strategies. I would recommend using role play to mimic their communication skill or with the AI. And also using reflective prompts for students mostly right now. Here are some more technical prompts, including zero shot that I mentioned. Shot means example. So zero shot means no example has been provided. One shot means you provide one example. So if you provide one example, you see here, if I want to translate nursing terminologies to layman terms, I provide example here what it means by dressing intake, GCS, and vital sign stable, okay, in a natural language term. And then you provide number 3 as the example, and then the AI will learn your translation ability to give you the answers you want. And the most commonly used one is the third one, few shot prompt or few shot learning, which means you provide number 2, 3, 4 here as the examples, and then the AI could learn from your explanation examples to translate these learning terminologies, layman terms for you. So this is what we call by few shot learning. Another very common type is chain of thought prompting. So also chain of thought learning, the same one. So chain of thought means you elaborate the blue, highlight the blue color here. You elaborate to the AI how you calculate this or how you interpret these sentences. And the AI will try to utilize your chain of thought, your thinking process to generate the answers for you. Okay, so the next one is about retrieval augmented generation, RAG model, which is also very commonly used in the chatbot or systems right now in their organization level. The main task for retrieval augmented generation is if you have some dedicated or localized database, you want to connect it with your chatbot or you want to connect it for your system. You can use RAG to specialize or to only retrieve data from your local database. Okay, so this is a very useful tool or a mechanism to develop some specialized virtual assistants or to create content generation for you. The next one is about, this is the mathematical or engineering architecture about how we use encoder. You don't need to fully understand this graph, but just remember, retrieval augmented generation means they try to retrieve from your local database and then try to generate these data based on your local database. And there are also some terms explaining what kinds of fine-tuning means. So you know that we use the commercial model of OpenAI, the ChatGPT or DeepSeek. But actually, you can deploy those large language model at home or in a computer at hospital if the hospital allows you to do so. So how you can actually develop your own chatbot is you can do fine-tuning, or what we mean by full fine-tuning is you change some kinds of parameters on the retrain the LLMs, try to adapt with your current task. So you can see here, this parameter, you might not know what it is. I have a highlight here. Parameter means is how do you want the computer to learn faster? How do you want your computer to learn your data set? How much time? So batch size, number of epochs means the parameter you want your computer to learn faster or a much more granular way. So you can go back here to see actually full fine-tuning might take more time, but the second one, the parameter efficient fine-tuning is actually make the task much more quicker. Okay, so just imagine that you want to rewrite the entire 1,000-page textbook. Right now, you just need to add some few pages containing some important notes or some specialized information, which could actually make your training process much faster and cheaper. And that is what we call by parameter training, parameter efficient fine-tuning. And the third one about the low rank adaptation is one of the example we use very commonly to train our dataset much faster. Okay, so here are some concepts about prompt engineering recap. Is how we want to modify the model behavior by providing a clear instructions. And the second one you learn is RAG, retrieval augmented generation is when you have a library, a stored PDF or some nursing guidelines, you just want your chatbot to learn and retrieve data from your own database, you just use this RAG, the RAG. And the last one is you can improve the efficiency by training the fine-tuning or fine-tuning a current model so that you can improve the efficiency of your chatbot or system with AI. Okay, then let's move to the agentic AI. So this is a term talking about you want the system to accomplish a specific goal without or with very limited supervision, which actually they also learn how the human make decision and solve problems. So in the previous slide, we mentioned about Gen AI, which can create content, doing data analysis in a Q&A mode, right? But agentic AI is different. Agentic AI is they could make decision for you. They could do problem solving. They could automatically work on themselves without or with very limited supervision. So here are some examples about agentic AI workflow. So let's say you see from here, the AI installed in the hospital with electronic health record. You can see from the perception, they can gather these data inputs, and then they have some knowledge integrated. And there are some action planning with goal-driven has been divided by the planning side. What the agentic AI could do here is they could continuously learn from the EHR record. They can try to call different types of API to do your specific task. So the agents could work together within the agentic AI. And then the deliverable would be, for example, they could generate a nurse summary based on this kind of EHR data, or maybe this patient has been sent to the OR or sent to the radiology room or for chest X-ray, and then they come back. You can have a summary generated automatically by the AI. So then you could go back to the human oversight. So this is one of the example from the latest publication from a scoping review. And then another very key analytic skill set currently in 2026 is the mixture of agents. It's quite similar to AI agents, but this kind of mixture of agents is, you can see, layer 1, layer 2, and layer 3 is they try to keep repeating iteratively to enhance your generation quality. So they do one time, second time, third time, fourth time in order to make their response much more precise. So here I highlighted their prompt. Actually, they developed for the mixture of agents. So this one, you can see that you have a set of responses. And then the main task here is they ask the LLM, your response should not simply replicate the given answers, but you should offer a refined, accurate, and comprehensive reply to the instruction. So these are very different prompting skill compared to the previous one we just learned. The mixture of agents could keep refining themselves iteratively. And another example here is in oncology. So you know that in oncology settings, there are some tumor board meeting, right? And this kind of tumor board meeting requires a multidisciplinary team to discuss together. So this study also employed the AI agents, how to actually deploy multi-model clinical knowledge base, including text, including images, and also some clinical cases as the clinical repository. And then the second one, they use some reasoning framework, how to guide the presentation, including diagnostic agents, how to diagnose this patient, what were the staging issues, what kinds of treatment, agents, monitoring, and coordinator. So you can see from here, 1, 2, 3, 4, 5, we have 5 agents work together to develop this reasoning framework. And then this framework also based on some integrated MDT, the multidisciplinary team recommendation, and they based on the benchmark evaluation. So the main thing of this study is they know that the MDT discussion by the oncologists, they take time to reveal the cases, they take time to know the current benchmark, the current case study. So they utilize different types of agent to work together and then give a more comprehensive integration of the data for these MDT domain experts to make the decision much quicker than before. So what kinds of clinical governance of AI agents we are currently dealing with? There are several ways. The first one is human in the loop. This means in the development process and the validation process, you should engage nurses, doctors together to spot some of the ambiguous or high-risk, unethically sensitive decisions. The second one is a comprehensive audit trails, including you have to track who has been revealed, who has been accepted, modified, or who should take the accountability of the AI-generated materials, and who will be the person to be accountable with if there are some side effects happened or some hallucination issue happened by the AI. And you also need to do some hard scope limit, which means restrict some use for some patient group that you think is not ethical. I will explain more later. Or to define what exactly this AI agent could do and what exactly they couldn't do. So part 4 here mentioned about how we could actually integrating compassion and algorithms together. First, we need to have system thinking. In order to give some critical feedbacks for the AI team, you need to learn how the AI could affect your current triage pathway in the hospitals or in the community settings. What kinds of diagnosis the AI would do the best? What kinds of diagnosis the AI couldn't do? What kinds of documentation they are trained on? And what kinds of documentation they couldn't learn from our clinical workflow? So before you critically analyze the AI system's performance, you should be aware of their training, be aware of their limitations. And then you can also recognize some kinds of data that could also have different types of multiple downstream decisions. For example, data interpretation, you can try to distinguish some meaningful signals across different types of false data or incomplete data. You can also have some clinical decision making based on your current understanding and how to maintain the patient safety in the AI development. The last one is you have to know how to identify these AI tools, how to be trained, and where these errors may occur. So this is like a back and forth communication between their team members. We usually will feed you some kinds of scenarios or some personas. What kinds of patient would be used it or would like to be equipped to use this AI tool, and what kinds of side effects if there are some uncertainty has been popped up. So interprofessional collaboration in AI-enabled teams is important. So decision-making, it should be in team-based. So the nurse could collaborate with a big team, including different disciplines. So you can share your frontline insights. What actually the clinical frontline doesn't work might have been deployed to the AI. And because most likely the AI tools were developed by the engineers in themselves, they might not have the clinical sense whether it's applicable or not. The second one is, do they really help with your workflow issues? Would there be any patient care gaps driven by the AI? The second one is workflow integration. So nurses should ensure the AI is embedded into the care processes properly. For example, it could reduce some alert fatigue. Otherwise, the AI keep in the ICU setting will keep alarm you, and you will be also very busy, right? So you need to design how often they would have their alert, or how often you can accept the warm force alert fatigue. You should have that matrix developed for the engineering team. The third one is communication across disciplines. Explain your alert matrix and recommendations, and also try to clarify some patient responses or preference, so that the AI tools could be developed with more contextual or culturally embedded factors that the AI may miss. The last one is the leadership role. Nurses should also have the ability to be participated in the design and implementation, also advocate for some practical or usable safe AI systems. For example here, AI for early detection for patient deterioration. So the nurse could help define the actual clinical problems. For example, like what signs matter most in the real practice, vital sign trends, reduce the urine output, confusion, what kinds of increased work of the breathing, family concerns, something like that. And then you can observe whether there are some relevant data input in your hospital or community settings. Like, you have any good data with the bedside observations, any nursing notes that has been digitalized or capture the symptom descriptions, what kinds of escalation events has been documented, and whether the AI could understand your documentation or understand the triage workflow. And on the other hand, the nurses could also shape the workflow logic, like who should receive this alert? What kinds of action is realistic for bedside nurse to take? When should the nurses reassess or notify the physician or notify the engineering team when there is an issue? And how we can activate the rapid response team as well. So these are the role of nurses could involve in the settings, how we can train the AI better or to figure out the contingency plan if the AI could make mistake. So this one also important for the capability is about the ethical AI stewardship and nursing advocacy. So 2 years ago, if you talk about AI, everyone would be, oh, it's very efficient, or like it's also some have concerns. People are quite dynamic, right? They might have some different opinions. But now, because the chatbot and also LLM has become very mature, more of the attention has been moved to the ethical concerns and the safety issues, because we are trained as a licensed healthcare professionals, because we have accountability. But the AI accountability issue hasn't been shot out, and in the current settings, especially most likely in the hospital. So you need to make sure these recommendations are fair, transparent, and clinically appropriate. So there are some metrics to like evaluate whether you as a domain expert in certain area agree that the recommendation could be fair or appropriate for a certain population suffering a certain disease. So this could make sure the bias or the risk has been maintained at a very low level. And also there's very limited privacy breaches could occur during the AI usage. And also patient advocacy is another issue that you might need to speak up to you. Oh, my AI didn't say, or my AI didn't recommend me for this treatment. You might need to prepare yourself how to teach the patients how to verify the AI recommendations, at what rationales, at what nursing practice, what kinds of theory that you are supported. So this might be some advocacy issue you also need to be aware of. And the last one, I also want to mention about the bias. So this could be keep evolving because every AI will be trained by different kinds of language models, and also different types of data. So it could lead to different bias on the age, on the race, or disability, or access rights among your population group. So when you practice or try to use the AI system, you need to keep thinking about what are the marginal groups that has been missed in the training data. So then you could provide some guideline for the next generation of the nurses. You might need to be aware of some kinds of population might not be well captured by the AI. So when we should say no to AI, some example here, people with end-of-life conversations, grieving support, which should require some human presence, sexual assault forensic examination, which require trust and consent and also prompt treatment, or some first disclosure of, for example, cancer diagnosis, which should also have the nurse judgment and maintain transparent and support empathetic communication with the patients. Or in some cases, the AI tools might not perform well with certain population group. And you should also have the ability to disable or to bypass the AI without any penalty, because we are the people to take accountability with the work we conducted here. So some curriculum and workforce implications in academia, especially in undergraduate level, we started at PolyU. All the students have to learn AI analytics and also AI applications in nursing. For assessment, also, we have to teach the future nurses how to actually simulate these AI outputs and how to override with your clinical judgment instead of just trusting their AI systems all the time. The third one is research priorities. What kinds of equity impact or AI evaluation specifically to nurses should be developed? Practice also very important is how we can encourage more nurses to have some nurse-led applications, co-design with the nurses, and also have some protected time from their clinical work to allow you to learn more about the latest trend of the AI tools. So some future research and practice horizons here. I don't want to mention all of them, but the main key issue is co-design with nurses, and also have some nurse-led innovations, learning different types of analytic skills, and also understanding some basic architecture and training materials of the AI is very important. And currently, agentic AI is a new trend. However, it hasn't been deployed to the hospital yet, especially in Hong Kong. And for the community nursing, home-based care also requires some different types of governance frameworks. We're urgently developing these kinds of things to protect the clients. So some brainstorming discussion, you can think about it after this lecture. There's no right or wrong. What kinds of AI tool in your setting you trust the most or you trust the least, and why? Where should the nurses' role boundaries be redrawn in the AI integrated workflows? And how the NGOs or community nurses can lead different types of AI adoption? And what would a compassionate AI policy look like in your own organization? The main question right now is no longer whether AI belongs to healthcare, but it's about how quickly we can be responsible to integrate and validate them ethically and safely, because the AI tool could change. Few years later, we might not be speaking on about AI. It might change to another tool. But how we as a nurse to safely guard our patients' life and also make our tools much ethical and more safe is our responsibility. So welcome all for your questions, and I hope you enjoyed this webinar. Thank you.